to part 2 of Module 6. In the previous section, we discussed how Medicare calculates reimbursement for many procedures. In this section, we are going to pick up with that and discuss some specifics for NPs and PAs, as well as discuss how some of these measures are used to evaluate providers in terms of productivity. So let's now talk about, I've sort of talked a lot about the role of the PA a little bit, and there's some quirks that PAs in particular and NPs need to be aware of when it comes to billing, especially Medicare, but also other providers. And so it's this idea of direct billing versus incident to billing for advanced practice providers. Okay, so this was the calculation that I showed for that simple laceration repair. And the reality is that CMS does not pay the full PFS rate for care provided by NPs and PAs. So they reimburse at 85% of the physician rate if it's direct billed under the PA's NPI. Okay, so if we're not going to get that full 104.91, you're only going to get 85% of that, 89.17. So the reimbursement is going to end up being a little bit less. Okay, and so this leads to this sort of split. Two different approaches. So care provided by the PA can either be direct billed under their NPI, or it can be indirectly billed as incident to a physician's care. Okay, so basically saying that we're not going to send a bill saying that this PA cared for this patient. The care was provided by a competent licensed expert and everything, but we're sending all the bills under the supervising physician's NPI. You'll get paid, the organization will get paid the full 100%. So they're going to get the Medicare reimbursement at the full rate. But the physician has to either spend more than 50% of the total time with the patient on the date of service, or make and approve the care plan and assume all the responsibility and the risk. And a key thing, this isn't my words, this is a very strong emphasis from CMS. A signature alone is not enough. So it's not enough that, the doctor's going to sign all of them, and then now we're getting all the, we're going to get the full amount. That's not how it works. And we'll look in the discussion board. That's one of the decisions that has to be made. Does it make more sense for the practice, to do direct billing and have PAs see all their own patients, of course, within their scope, or should you try and have the PA try and do 50% of the care, and then you have a doctor run around at the beginning and the end, so that you can say that the doctor did all the care and bill all at that rate. It's really an operations management question. Or should the PAs see their own patients and the doctors primarily see their own patients, and now both folks are billing independently? You're probably able to see more patients that way, and probably ends up working better for the practice in that way. So we've seen sort of this shift over time. So in 2018, most care was provided indirectly, or most care provided by NPs and PAs was indirectly billed. So if you look at, so this bar here on the right is practices where between 80 and 100% of their billing was indirect, and is 70% of practices. So this was 2018. Things have shifted, though. In 2022, under the Consolidated Appropriations Act of 2021, PAs were able to bill Medicare directly. Overall, direct billing for PA care has a lot of benefits. It reduces revenues to practices, but overall, for the same service, but overall, you're probably able to see more patients. Rather than having a doctor come behind every PA so that the doctor can sign it. Overall, it saves Medicare money. So, I think direct billing overall is probably beneficial. The 85%, I think there's some discussion there. Is that the right way to go? Or if the same service is being provided, should it probably just cost the same? Here I'll venture into a personal opinion. A simple laceration on my finger. I'm only an EMT, but I could tell it's clean. It was a clean cut. I cleaned it. I've stopped the bleeding. I just know it's in a weird spot. It was right on my knuckle. I'm going to need stitches, right? And so a doctor wasn't going to do a better job than the PA who stitched it up. So I didn't get anything more. I wouldn't have gotten more healthcare, or better healthcare going to a doctor versus a PA. So why would the hospital have gotten paid more to have a doctor provide that service? Pricing in any other industry, it's based on what you get, not who provides the service necessarily. It's the same service from two different people. Service should cost the same. That's just my opinion. Again, this is what is, not what I think it should be. Okay. But ultimately, this leads to a practice management decision. And if you're in that leadership position or advocating for how PAs should be used in a particular practice, or what should the role be, you've got to decide: are we going to do direct billing? Should PAs see their own patients within their scope of practice and accept 85% of the reimbursement, again, under the current system? Or should the workflow try to have physicians proceed and follow the PAs to bill Medicare at 100%? I've talked to a number of PAs where, the practices were we're kind of going to go away from hiring PAs or, having per diem opportunities for PAs to help because we get paid less. And it was a great quote from a PA. Actually, she, I don't want to out her, but she teaches in this program. And she was, she told this story. Basically, they said, we can't afford to pay you and not get 100% reimbursement. And she turned it right around on him and said, you can't afford to not pay me and accept 85% reimbursement. So just something to keep in mind. Okay, so we've talked a lot about Medicare. Let's talk about private pay reimbursement rates. So how much are you going to get reimbursed for a third party, insured patient? So patient with United Healthcare from their employer, Target, whoever. Back to my old favorite emoji. I don't know. Nobody knows, right? So we have all these formulas. A lot of payers do similar things, but as we discussed in the payment structures lecture, there's some just completely different structures where it's not fee for service. Even if you do have a fee for service structure and the patient has their plan is fee for service, how much you're getting reimbursed, it's the Wild West. So private payers do not necessarily, again, follow this Medicare model. Fee-for-service, still the most common, and pricing oftentimes is benchmarked to Medicare, and there's a similar structure, okay? But you might have just per diem rates. It's per day of service for inpatient services, not a DRG. You might have case rate, okay? So it's similar to the DRG. We've got this bundle payment for a knee replacement. Capitation, that's where you get X amount of dollars for all these patients, and whether they show up or not, that's what you get paid. So the workplace clinic, that's pretty much what you've got going on, right? You're getting X amount of dollars per month, you got to make it work. And then you've got value-based contracts that get way more complicated, like the level of care, readmissions, all this stuff. It's private parties. You can do whatever you want. You can negotiate pretty much any contract you want and any contract structure that you want. So, just to sort of emphasize or underscore this, let's look at what mHealth Fairview charges for different CPT code, or charges different payers for these CPT code 1202. Again, that's simple repair of a small laceration. So their nominal price or their charge is $545. So that's what they say. Hey, this costs $545. But it actually ends up being quite a bit different based on who's paying, right? So United Healthcare Commercial is going to pay $13.83. Whereas if you're a cash patient, you're going to get a discount of 60%. You're only going to pay $225. Okay, so it's sort of all over the map. Medicaid, so that PMAP, $160.95. No surprise there. Okay, so but this is where getting back to where we opened today with, like, what is this going to cost? I have no idea, right? And for the same procedure, one patient, the hospital may get $160. For another patient, the hospital may get more than $1,000. So it's like a 10x difference. How is you as the clinician are supposed to know? No idea. No way you could possibly know this, right? How did they come up with these numbers? It's all contract negotiations, and a lot of these are secret. I'd love to be able to show more details, but like all this stuff is kept confidential. And so despite efforts to increase transparency, ultimately the price and reimbursement associated with a particular encounter is really difficult to predict. So this is a price posting for mHealth Fairview for their clinics for typical things that they see, I think, in the outpatient clinic. So level 2 outpatient visit, the provider charge is going to be $298. And then this is sort of like the average reimbursement from commercial payers. But again, you see there's a big range, and it's still very, very difficult to predict. Okay, just a couple more things, and then we'll end this part of the module. So let's talk about RVUs and productivity measurements. So RVUs are used to calculate reimbursement. That's a fact, right? So if you have a Medicare patient, we're gonna use the RVUs that you stitched up this finger, and that's gonna determine what the hospital gets paid for that procedure under Medicare fee-for-service. That's a fact. RVUs, like so many other things in healthcare, we brought them in for one purpose, and then we started using them for other things. So we say, well, the Medicare said that this, activity is worth this much, this activity is worth this much. We're going to start to use this for productivity measurement, okay? And hospitals are paying a lot of attention to this. So this is from Hennepin Health, the financial statement from 2024. So they released in early 2025 their statement for the previous year. And we see that right in one of their early tables, okay, table 4, pretty, towards the front of the report, they're reporting the work RVUs performed by their PAs, NPs, and physicians. Okay, so this is a big number that hospital and health system management is tracking. Again, positivist view. What is the reality on the ground? They are tracking work RVUs that are conducted. Okay, and for a lot of folks in practice, that means your activities are being tracked. Of how many WRVUs, work RVUs, are you producing for the organization? And as we'll show, maybe that's not the best metric, but it is happening. So you probably want to be aware of it, and you want to understand, okay, what is this leaving out? Okay, so let's look at the work that's going to be done under this CPT code 47562. Cholecystectomy. I always have trouble with that word. Okay, so got this patient, gallbladder. It's all messed up. We got to get that gallbladder out of here, okay? So think about all the work that goes in to make that happen. So pre-op, we got to do H&P. We got to get consents. We have to talk to the patient. We need to teach them. We need to get everything scheduled. We need to do pre-op physical. We need all the things that have to happen before the surgery are going to be bundled in the payment for the surgery, right? But the only part of the surgery that is assigned any WRVUs is the work done in the OR. And only the surgeon is going to have those associated with them. So then let's say that post-op, there's a bunch of post-op management, okay, that you as a PA are picking up, okay? That may not be associated with any RVUs. So the pre-op, the post-op gets 0 RVUs. The surgery gets all these RVUs. Well, it looks like, well, what have you done? You did 0 RVUs. Going back to the financial statement for the year, you didn't contribute to this line. When, a huge part of your job may be really, really important to actually getting the patient into the OR, or whatever your particular practice area is. But there's a lot of things that don't generate any WRVUs. So this is from a really interesting paper that looked at advanced practice providers specifically in an oncology setting. But I think a lot of the takeaways apply across different scenarios, and across practice areas. So think about the value add activities that are not tied to any WRVUs. And here's a list here. So, peer-to-peer review, getting prior authorizations submitted, hospital admissions, rapid response code team duties, right? Committee work, teaching, precepting, is not going to generate any WRVUs, is not going to generate revenue, but it's super, super important. And so it's not necessarily fair to, base somebody's evaluation just on how many WRVUs they produce. So let's think about the key insight here. Metrics like prescriptions, MyChart messages, treatment plans, procedures, and patient contacts may capture PA productivity better than the WRVUs. So what metrics are we using to evaluate PA productivity? And are they the right ones? And are they really capturing the totality of the contribution that the PA is making to practice? All right, so I know this is long. We'll pause the module here and pick it up in part 2.